So we'll go ahead with the second talk is going to be by Dr. Amit Porwal. Dr. Amit is going to talk on Morgagnian white and Intumescent cataract technique to manage Argentinian flag sign. So Dr. Amit, you all know he's the member of AIOS scientific committee as well as ARC. And I've seen this talk given by him quite some time, and it's a beautiful pearls he's going to give to manage the white Intumescent cataract.
Thank you, Dr. RP. It's a pleasure to be part of your instruction course. So the topic has already been mentioned. I got no financial disclosures. So Argentinian flag sign was a term coined by Daniel Perón. Basically, it's a peripheral split or radial tear in the anterior lens capsule after the first puncture while doing capsular access in white mature Intumescent cataract, whose capsule has been stained with trypan blue. Only when the capsule is stained with trypan blue, the split resembles the Argentinian flag sign, and we call as the Argentinian flag sign. What are the problems we face in this type of cataracts? There's difficulty in visualizing the anterior capsule. The capsule is more stretched. There can be a peripheral split which can lead to the Argentinian flag sign. There can be mid-periphery extension of the capsular axis, and sometimes there's liquefied matter which is liberated with my hospital view. So you can see this was an Intumescent cataract. I've started with my axis, but the initial curve which I wanted, I couldn't get it, so I thought it might extend. So now what I do? I felt that the intraventricular pressure is high, so let me decompress it. So I tried to introduce a cannula and I tried to decompress and see what happens. It's an Argentinian flag sign. Now if you get this Argentinian flag sign, how you are going to manage it? This is very, very important. So basically in this there are sharp horizontal edges. So whenever you get this type of sign, you reform the anterior chamber with the cohesive viscoelastic, give a small neck, and with the help of a microrhexis forceps, you convert these sharp horizontal edges into a circular ones. Why this into circular ones? Because the vector forces then will be distributed uniformly over the entire area, and this Argentinian flag sign won't extend posteriorly and cause a PCR. Mind you, you have to refashion the rexes, both the inferior part and the superior part. Whenever you feel that the AC is becoming shallow, reform the AC with the help of a cohesive visco, and with the help of a microrhexis or a microvanas with both right hand and left hand to be used, and you can convert these sharp horizontal edges into the semicircular one. Well enough that when you put the IOL, there should be enough coverage of the optic of the anterior capsule over the optic of the IOL. Another option is basically you can convert into a can opener capsulotomy. When you convert into can opener capsulotomy, never proceed with your phaco. Always make sure that you convert into a manual small incision cataract surgery and finish your surgery. Sometimes what happens, this is an Intumescent cataract, you have got the initial tear, you are doing the rexes, and because of AC becoming shallow, sometimes the rexes get extended in the mid periphery. If you get this, stop then and there, reform the AC, and from the opposite side of the rexes where you are not extended, you give a small nick with the help of a vanas, and then reform the AC, and then with the help of a rexis forceps or a microrhexis forceps, whatever you are comfortable with, and depending on the size of the wound, you refashion the rexis from the other side. So this is the way you are going to handle it. Now if you are proceeding with phaco in this type of cataracts, what are you going to do? You have the Argentinian flag sign, and most of the time these cataracts are soft and fluffy. You have to make sure that the irrigation port of the sleeve, they don't direct on the split end of the anterior capsule, because if these jets fall on that area, then these rexes might extend posteriorly and might cause a PCR. Whatever is the preferred technique of phacoemulsification, whether it's a direct chop, stop and chop, continue with that, but just make sure that your parameters are lowered down. You do a slow motion phacoemulsification, and most of the time with simple aspiration and a bit of phaco energy, you can emulsify the whole of cataract. And then once you put the IOL, then if you think that the optic coverage is more, you can refashion the rexes. But only the important point is that you should always make sure that you do a slow motion phacoemulsification. Now coming to the main thing, we don't want this complication to occur. So what are the techniques which we can do to avoid this Argentinian flag sign? This is all we want. So what is described in the literature is a mini rexis, a snail pattern or the onion pattern rexis, a heart-shaped rexis, or the Dr. Mohan Rajan's technique, which is pancho rexis. But what I recommend is, basically you can see in this is a mature Intumescent cataract. So always staining of the capsule with trypan blue is a must. Why? Because this elastic capsule becomes more brittle when you stain the capsule with trypan blue. Cohesive viscoelastic is injected, and a 260 syringe, a 24 gauge needle is mounted and pierced into the center of the anterior capsule. Only the bevel is pierced, and you stay there and aspirate, and you saw that the central part got decompressed, and whatever was convex has now become flat or concave. Once you have done that with the help of a capsulotomy needle or a micro rexis, whichever instrument you are comfortable with, make sure that the AC is always formed and try to start the rexis. Always begin with the small rexis, and once you have reached the initial prick point, you can go beyond that, and now you are doing it snail pattern or onion ring pattern rexis. So I always prefer to make sure that we have a smaller rexis, not mini rexis, a smaller rexis, because that gives more comfort and the chances of tear is very less. Once this rexis is done, you can emulsify the cataract, inject the IOL, and if you think that the rexis is too small, you can refashion with the help of a micro rexis and micro 1Rs. Quite a few times we get a decentered rexis. So I've given a small nick with the help of a micro 1Rs, and through a micro rexis forceps now, I'm refashioning the rexis so that I have a circular central opening and a well covered anterior lens capsule over the optic. So doing a small rexis and then converting always helps. You can see another case. A 2cc syringe is injected, pierced into the center of the anterior capsule, straight there, only the bevel down, and you saw the concavity which occurred when you are aspirating it. We did a study, we compared with 5 ml, 2 ml, 26 gauge needle, 24 gauge needle, and we found that the 24 gauge needle is adequate size. Now in this, the tear was in a different direction, so you should be smart enough to understand whether you are going to start your rexis from the right hand or the left hand, or the right side port or the left side port. So here I started with the left side port with the help of a capsulotomy needle, and in between I felt when the ergonomics of my wrist is not helping me, I changed the direction, and then from the other side port I started completing the rexis, and you can see how nicely the rexis is completed. Another way of tackling is doing an anterior yak capsulotomy. A single shot of 1.2 millijoules in the center of the cataract is given with the anterior yak laser, and once you pierce it, there is a gush of fluid. You shift the patient to the OR. By that time, the whole interventricular pressure bag is decompressed, and what you get in the OT is, after you stain the capsule, you get a striate color opening. You can see in this, there is a gush of fluid like a waterfall. You can see one shot, and there is a gush of fluid falling down. So like a Niagara fall, everything is falling down, and nicely it gets decompressed. So how the capsule looks after you've done a yak capsulotomy, it is a striate pattern opening. So with this striate pattern opening, with the help of a micro rexis forceps, you can start your rexis and you will be very comfortable. The AC depth increases after this yak capsulotomy. That means it was an intumescent cataract and the AC depth has increased. We did a study in which we enrolled 52 eyes of 52 patients, and we compared preoperative ND-yak anterior capsulotomy and said that it is a safe and effective technique in reducing intraventricular pressure and avoiding intraoperative complications in mature intumescent cataract. We published this in Asia Pacific Journal of Ophthalmology and was also featured in the AO Academic Express. We did one more study in which 100 eyes of 100 patients were recruited. In group 1, preoperative anti-yak capsulotomy was performed. In group 2, intraoperative 24 gauge needle decompression was done. And the outcome was basically lens decompression needs to be repeated, is an ideal technique to manage these cataracts. Lens decompression technique reduces the need for repeated entry of instruments in the anterior chamber. A perfect central opening is achieved in a single opening, and there is no complication rate at all. And this one the best physical posture also. So my tip for managing this mature intumescent cataract is intraventricular decompression by whatever method you are comfortable with. Go ahead. So there are two options which I described and which I published. One is ND-yak laser capsulotomy, and second one is slow and guarded decompression with a 24 gauge needle. So this is the most important tip to manage these Morgagnian intumescent cataracts. Thank you.
Thank you very much for your wonderful presentation, how to manage these intumescent soft cataracts. The important point when you are dealing with these intumescent cataract, because your idea is to decompress the back. Your capsule has to be flattened before you start the capsular axis. So you have several techniques for that, as Dr. Amit has shown beautiful techniques. And once you decompress, then the chances of extension becomes very low. So before you start the capsular axis, always decompress, and the decompression has to be done complete before you start the capsular axis. So that is very important point. Doctor,
yes. What was the power, and how the size was you measured that?
No, the yak machine has a power setting. So we use an upper yak laser. Upper yak laser, it is 1.2 millijoules for Mark II. So you keep the setting on Mark II and give one shot in the center. That's it.
One shot.
So one shot, it gives enough good opening, and when this laser shots, it's like a flower petal. So there are multiple flower petals opening, and there's a gush of fluid. And this never extend, because the moment the energy is the shot is given, the whole thing falls down like a waterfall. So we didn't have a single extension of this rexis. And it is something different. With laser, we get a striate pattern, and with Dr. RP introduced the sewing needle technique. That needle is round, so that when you pierce it, only thing is what I used it, and I felt that you need to apply some pressure to pierce it. Otherwise, once you pierce it, the hole is totally round like a punched out hole. So anything, whatever technique works should be used. Main thing should be intraventricular decompression.
please, any comments?
So I can show you a 30-second video of mine. I use a retractor axis instead of puncture axis, where I use a retractor tip and maybe 3 or 4 cuts with a 600 vacuum, which is pretty high. As soon as you cut, the tip of the retractome enters the lens, and the whole liquid cortex is sucked in 5 seconds. So it becomes concave immediately. So initially I did YAG anterior capsulotomy, capsule puncture also, YAG puncture, and everything I have done, but most recently I have started doing vitrectomy, using vitrectomy to puncture and to aspirate the cortex, and that is something, again, it's one of the variants of what Dr. Amit has told. So whichever way you want to do, you have to puncture and aspirate to debulk the cortex, so that the anterior capsule becomes concave and there is no enhancement or increase in the size of the puncture. That is the ultimate thing.
Problem comes up when you do not have any fluid in the interlenticular space. It's just the swollen cortical material. It's swollen cortical material. So there, the puncturing or aspiration won't work. So what do you do in these cases?
See, if the vitrectomy probe is there, it cuts and sucks both. So even if there is hardly a little lesser fluid, it will cut whatever is there, it will cut and aspirate both together. So this works in every kind of bulging nucleus where there is a turgid fluid inside and there is a intralenticular pressure which is higher. So it works very well in all my cases.
That's good, yeah. Thank you very much. Thank you. Yes.
Sir. Yes.
Stretched.
Yes. Yeah.
No, it won't happen in the calcified, but generally what happens, it's a swollen cortical material or swollen nucleus also, like we see normally with the phacomorphic glaucoma. In phacomorphic glaucoma, you don't have fluid, it's the swollen, the whole lens material swells up, even the nucleus becomes very voluminous, and there, puncturing won't work. So there are several techniques, Dr. Amit will let us know. One of the, you do the anterior vitrectomy also before you start the capsular axis, just to decompress the whole pressure which is developing in the interlenticular space. So you do the vitrectomy, so the whole thing goes back, and then you can start the capsular axis. The idea is you have to, if you are able to decompress, then it's fine. If you are not able to decompress, then you have to make a microraxis because double raxis or microraxis, because you have to make a central small hole actually in the lens so that the hole will not extend. So we do the microraxis, small raxis, or my technique which is called the sieving natal microcrystallotomy. So these techniques work then very well. So thank you very much.